So the design of the study was very unique because we kind of leveraged this unique linkage we had between administrative data and patient-reported outcomes that were collected during interviews conducted with the patients 1 month post-discharge. And this is actually a follow-up study that we did as a continuation from a previous study where we identified those frequent emergency department users using claims data. We looked at administratively derived risk factors for frequent emergency department use. And in this phase of the study, we really wanted to look at the discharge experiences as reported by the patients. So the main goal of the study was qualitatively looking at the different challenges and concerns that patient reported during that 1 month post-discharge, which is a very critical period following a hospitalization. And we wanted to see just descriptively if there is anything that stands out that may potentially result in an increased risk of acute healthcare services post-discharge. So we had a very good sample size for these interviews. We had around 200 patients that were discharged from the hospital and eventually became frequent users. So we analyzed the interviews for these patients, and there were multiple themes that emerged. There were around 7 or 8. And the main ones were related to medication communication and medication information given to the patient at hospital discharge. So the first one was really about was medication information, whether in terms of medications prescribed or the discharge papers, communicated to the patient when they left the hospital. And so we saw that especially for pain treatment regimens where patients are on multiple drugs, patients left the hospital without knowing how to really administer those medications. And given that they were told to gradually decrease these drugs, it became confusing for them in terms of how this was supposed to be done because they left the hospital without any explanation. There was a lot of patients who also mentioned that they didn't know what the post-discharge period was supposed to look like for them in terms of recovery time, whether or not information was communicated to their community prescribers, whether or not they had to seek any follow-up appointments with the prescribers. And so all of this was really confusing for the patient, and I think it resulted in a lot of them seeking ED, going to the hospital for ED visits because they really didn't know what to do with any emerging problems or worsening of their conditions. We also saw that there was a huge problem with communication among the team members as well. Patients mentioned that physicians are not communicating with each other. There is a lack of coordination. Their discharge planning is just either rushed or it's too early, so patient felt like they didn't have enough time to recover before being discharged. So that was really one of the few main themes that emerged. We also saw that patients mentioned the lack of scheduled follow-up appointments. Nobody was monitoring them post-discharge, so they didn't really have a resource to go and ask their questions during that follow-up period following the hospitalization. So we had a few patients that actually mentioned nurses as very crucial in ensuring that communication between the different divisions, between the doctors, then the community pharmacists, the follow-up appointments with the community prescribers. So I think this is one area where they can really be key in just making sure that the information is being transmitted to the community care team for that patient. I also think that in terms of organizing the hospital discharge planning, keeping patients' chart up to date, this is something that was also mentioned from our participants, is something that the nurses can really help with. Communicate with the community pharmacists, fax that prescription so that the community pharmacist is aware of the changes, and just make sure that that transition and communication is done like early on so that there are no gaps in healthcare for these patients. They don't have to go to the emergency department room to either get medications or just answer questions that could be answered over the phone. I think our findings are not extremely new in terms of the information that we're presenting. I think previous studies have identified very similar problems in terms of lack of communication, failure to communicate different changes in medications to the patients. So I think really we're highlighting that need for the ongoing efforts and strategies to either implement things that are already there so that we can optimize that transition for patients, or develop an alternative model that is based on either in-person interaction, so face-to-face interactions were found to be way more productive and better at improving these outcomes for patients later on. So definitely I think discharge planning should be based on multidisciplinary collaboration, this shared decision making that patients realized was lacking for them. I think it needs to be improved moving forward. We were really excited about this study because it kind of really follows, first of all, from a previous study where we did use administrative data, which is what is most commonly available. And so having this qualitative stories and these interviews, we're not only going to be describing them, but actually in the next step, we're going to try to quantify the risk with these different emerging themes and whether or not they actually lead to increased frequent use in the community. So there is more things coming up, and yeah, we're really looking forward to it.